Hi everyone. Today we are going to work through the approach to bruising and abnormal bleeding in children. I'm Isabella. I'm one of the fifth years on the academic team at Muppets. This is another area where you'll see a very broad spectrum of presentations from quite benign and common causes all the way to life-threatening diseases and child protection issues. So it's really important that you have a clear framework in your head when you're assessing this and perhaps approached with this in an apex, and keeping clear differentials in your mind of things not to miss. So these are some of the things that I'd hope that you take away from today. So recognize common and concerning causes of bruising and bleeding, understanding how to take a focused history and examination, know what initial investigations to order, and identify the red flags for urgent referral or escalation. Just like with the unwell infant lecture that I did, the trick is to combine a systematic approach with awareness of those high-risk red flag presentations. So when we talk about abnormal bruising or bleeding, it can be a little bit difficult to characterize what exactly people mean by that. So the definition that I've sort of settled on is that it's abnormal bruising and bleeding refers to bleeding symptoms or bruising symptoms that are excessive, recurrent, or occur with minimal or no trauma and are disproportionate to what is expected for age or activity. So it's not just about whether or not the child bruises. Most kids do. And we're all allowed to have, one really good bruise in our lifetime. But whether or not it's disproportionate to the story you're being told. So, for example, a toddler or a preschool age child might have a few bruises on the shins because they're learning to walk, they're getting their balance, they're mucking around. That's probably to be expected, okay? But a 6-month-old who's non-mobile with multiple bruises, different story, and one that's highly concerning. So context really matters. Now, these are the R1 and R2 conditions from the matrix that I'll be covering in brief detail today. It's not an exhaustive lecture, but these are the things that you want to keep in the back of your mind as differentials. I've got a system here that I think about it as. So trauma I think of first. So it can be accidental, like a fall, but it also can be non-accidental, which you must always consider if the history doesn't add up. Coagulopathies such as haemophilia or von Willebrand's or thalassemia, generally there'll be a strong family history of bleeding after hemostatic challenges, or even indeed a personal history that might point you in that direction. Platelet disorders like immune thrombocytopenia, which we'll discuss later, vasculitis like Hennig-Schwann and purpura, liver disease or malignancy, which we'll talk about malignancy today, but not liver disease. But again, it's easy to understand how both these things can affect clotting. And again, we won't talk about this today, but it's still important to think about. Very lucky in Australia, we don't have to think about it this much, but broadly, nutritional deficiencies too. So vitamin C causing scurvy or vitamin K deficiency. So history, lots of questions to ask. These, I think, are just some of the high yield ones. So key questions are the onset, frequency, and pattern. So is it new? Is it recurrent? Is it related to trauma? Have they had this happen before? Have they had this happen before but not in this setting? Really getting a good handle on what is the nature of this presentation. Family history, so important. So any bleeding disorders. Has anyone had a procedure and they've had complications because they haven't been able to stop bleeding? How has everyone else in the family gone, for instance, after they've had an injection? These are really key if you're thinking the coagulopathy route. Medications and toxins. Aspirin and NSAIDs aren't super commonly used in kids as they are in adults, but they're still important to think about because obviously they can affect your platelets. And anticoagulants, kids can get into cupboards and steal medication, so it's good to think about. Developmental history is obviously important in all pediatric histories, but mobility is a really important component. So could bruising be explained by activity level? The answer to that question will be how mobile are they? And what would be an expected pattern of activity or play for them at that age group. And then importantly, any concerns of abuse. And this is a hard one to do, especially in a time-pressured situation. And it's one that requires obviously a lot of delicacy. So it's an important consideration to think about. So how is home? and who lives at home, those type of questions. Other things to ask too is also ask about mucosal bleeding, so gums and bleeding from the gums and nosebleeds, easy bruising, and asking the child themselves if they've had any history of bleeding after things like immunizations or going to the dentist. So physical examination, look at the general appearance. So are they pale? Do they have jaundice? Do they look disproportionate for where you'd be expecting them to look given their age? Obviously, you'll be given these parameters in an APEX and examination with appropriate reference ranges or growth charts, but still important things to think about generally. Location and pattern of bruising. So I have a diagram on the right here that demonstrates typical, keyword, accidental and non-accidental bruising patterns. So this is based on preschoolers roughly, and the accidental bruising patterns really seem to follow normal patterns of play and falling, so on their shins, on their back, whereas the abusive bruising patterns tend to follow non-predicted or non-likely patterns of accident. So suspicious areas like the torso or the ears or the eyes. Looking for mucosal bleeding or petechiae. And then joint or muscle swelling, like hemarthroses or significant muscular hematomas, which may point you in the direction of a coagulopathy. And always palpate for hepatosplenomegaly or lymphadenopathy, because these might suggest malignancy or systemic disease. So what are your red flags? So these are the things that should immediately make you think of serious pathology or safeguarding issues. Bruising in non-mobile children. Okay, so those who don't cruise rarely bruise. A baby who isn't crawling or walking shouldn't have bruises. Highly suspicious for non-accidental injury, as is pattern bruises. These generally don't match accidental trauma. And then to tie this all together, a history that's inconsistent with injury. So if the story doesn't fit the pattern, take that seriously. Recurrent epistaxis or bleeding after minor trauma, so certain hemostatic challenges, if they have prolonged bleeding after that, this might suggest an underlying bleeding disorder. And systemic symptoms, as always, across all age ranges, these are always a red flag for malignancy or a serious systemic illness. Investigations, bread and butter investigation of all heme presentations is obviously your full blood examination with film, depending on the presentation, because you want to look at cell morphology. Coagulation profile if indicated as well too, von Willebrand factor studies, liver function tests, as that can also affect clotting, hemoglobin electrophoresis as well too, and then if there's significant concern for malignancy or the differentials or the diagnosis is unclear, a bone marrow biopsy might be considered plus or minus imaging. And then always interpret results in the clinical context. So a very mildly prolonged APTT in an otherwise well child who's growing and meeting all their milestones is a very different picture from a pancytopenia in a sick-looking child. So clinical context is really important when you're thinking about this. This is taken directly from the RCH approach to anemia. It's a good one to think about, and it really can work for adults as well too, and so it's handy to have in the back of your mind. It also talks about the type of cells you might see in a film that may indicate the diagnosis and what you should do next as well too. I revisit this every year, regardless of what I'm doing, because it's just so high yield. So iron deficiency anemia is the most common cause of anemia in kids, and it can present with bruising or pallor. So it's a good one to get familiar with. History, there's a lot to cover in the history for iron deficiency anemia when you're thinking about causes or mechanisms leading to iron deficiency. I've got a table there on the right that is a really good table, and it's sort of the 4 main ways you can think about how you become iron deficient. So are you not taking enough? Are you losing too much? Are you needing too much? Or are you not absorbing enough? And if you can remember 1 or 2 from each category, you'll be pretty sweet in an exam or APEX scenario. So dietary intake is a really good one. So are they vegetarian or vegan? And also to when they're little, or even indeed in some school-age children, asking about how much milk they're having, because that can interfere with the absorption of iron. And so it's a good question to ask of how much, if they're still having bottles, or if they're an older child, how many glasses of milk are they having a day, and potentially using that as a focus in management in terms of getting it down. Picker, which is eating bizarre things because you are iron deficient and you're trying to seek iron. So kids eating soil or craving ice, that's picker. Chronic blood loss, so in an older child, or sorry, in an older adolescent, menorrhagia is a really important one to not forget. And then in terms of, this isn't necessarily a cause, but iron deficiency can change your cognition, or impair it indeed. Developmental milestones are a really important part of the history. So how are they going? Are they meeting things appropriately? And then exam, depending on the extent of the iron deficiency or the iron deficiency anemia, you might find pallor, tachycardia, or delayed growth. Investigations, full blood count, obviously. And if they're anemic, you'd expect to see a low hemoglobin and a microcytic hypochromic anemia, but they might preserve their hemoglobin and just be iron deficient for the time being. And so that's where the iron studies are really important to confirm the low serum ferritin. And again, you've got to be mindful of interpreting these in the context of a sick child, because ferritin's an acute phase reactant. So you may need to retest in that instance. Then if you go back to that flowchart on the following page, if there's concomitant other things at play, other causes might need to be excluded. So management really depends on the extent of the deficiency and indeed the anemia, as well as the symptoms. So in an otherwise well child with iron deficiency, diet is a really great way to get control. So encouraging the consumption of iron-rich foods, meat, leafy greens, fortified cereals, oral iron therapy, so ferrous sulfate or equivalent for 3 months after normalization of the hemoglobin. It's important to remember iron is incredibly constipating in kids, and some of the times that constipation peaks in a child's life are also some of the times that they get found to be iron deficient. So it can worsen existing things. So it's a good thing to tell parents about in a counselling station, and also keep an eye on yourself. And then addressing the cause, obviously. So you can give them all the iron in the world, but if they're still losing, then it won't help. So if, for example, celiac disease is the cause, then putting them on a strict gluten-free diet. Or if in an adolescent they've got significant menorrhagia, then you might be thinking about the oral contraceptive pill or an intrauterine device. And then following them up. So you want to try and see them at certain intervals, and the RCH has a great page on this, because you want to keep making sure their hemoglobin and ferritin normalize and remain so. And then you want to reassess their adherence and their response, because given the fact, as I said, that oral iron tablets are incredibly constipating, you don't want someone on that for a very long time. So reassessing as you go. So if you're thinking they might need an infusion, or if indeed they're really anemic, they need a transfusion, there is a good when to refer bit on the RCH page. So immune thrombocytopenia can be a common cause of bruising in children. This is a little boy on the right, a little 2-year-old Australian boy who presented with ITP. And it can follow a viral illness, but it also can be idiopathic, which is important to remember when you're counselling about it. How do they present? So like this little boy here, it can be isolated petechiae, bruising, bleeding from the gums of the nose, but they shouldn't have any systemic symptoms, okay? And on their examination, you may see this petechiae or purpura, but there shouldn't be any hepatosplenomegaly or lymphadenopathy, because those systemic symptoms and the organomegaly and lymphadenopathy point in the direction of a more systemic and serious pathology, such as a malignancy. So full blood examination, what are you going to see? Isolated thrombocytopenia, so isolated low platelets, and then If the diagnosis is unclear or there's worry that there's something else going on, a blood film can exclude the other causes. So what do you do? If it's mild and there's no bleeding, and their platelets are greater than 20 is what they characterize it by, you can just watch them and safety net them. But if there's moderate to severe bleeding and or their platelets are less than 20, you may consider oral prednisolone or IVIG. You want to avoid NSAIDs because you don't want to lose any more platelets and contact sports. Most cases are self-limiting and will recover in a matter of weeks, but a minority do progress to chronic ITP, which is ITP lasting longer than 12 months. So this is not an exhaustive overview of ALL, and I'm not going to be going into the specifics of chemotherapy, but this is more a brief, understanding of how it might come up in an exam or APEX. So bruising can be the first sign or one of the first signs of ALL, and in the history, you can get a story of tiredness, bruising, recurrent infections, bone pain, fevers, and weight loss. So that classic B symptoms. When you examine them, you might see pallor, petechiae, hepatosplenomegaly, and lymphadenopathy. Tests, so your full blood examination, can show anemia, thrombocytopenia, or a low or high white blood cell count, depending on what's going on. And importantly, the blood film you must do because it shows blasts. And on the right here is a film of ALL. Coags, LDH, and uric acid become important when you're thinking about the diagnosis of tumor lysis syndrome potentially at play. And a bone marrow aspirate is the definitive diagnosis in terms of the actual cell morphology. And then depending on what else is going on, different imaging might be pursued as well too. Cytogenetics are important as well. Management is obviously specialist-led, so there's different phases of chemotherapy. They need supportive care as well too for other things that could come up, and very importantly, psychosocial support for both the patient and the family. It's a very, as we can all appreciate, a life-changing diagnosis, so this requires multidisciplinary involvement. The key takeaway for this, though, for the purpose of an APEX or exam, is that it's the red flag of bruising with systemic symptoms like fevers or weight loss, plus or minus on examination, organomegaly or lymphadenopathy. Okay, that's the must not miss part of this. Next up, we have lymphoma. Similarly to ALL, I'm not going to be covering this in enough detail, but just an overview. So lymphoma can also present with bruising, but often painless lymphadenopathy is the stem you get, and also systemic symptoms. Investigations are largely similar to ALL with the FBA, UEC, LDH, and ESR and CRP. Different imaging, obviously, too, to characterize it, and biopsies for histology. On the right, this is Hodgkin's lymphoma, a slide of that. And immunophenotyping and cytogenetics are also obviously important for characterization and prognosis. So management is varied depending on what the actual subtype is, and it follows sort of the same cornerstones as ALL in the setting of there's directed therapy towards what's going on. Then you need supportive care to prevent the sequelae from the cancer itself, the malignancy itself, or the complications of the therapy. And you need psychosocial support for the patient and the families, and obviously long-term follow-up. With lymphoma, suspicious lymphadenopathy greater than 2 to 4 weeks, painless lymphadenopathy, you must always investigate that, because that can be the first sign of lymphoma. And so anytime you hear painless lymphadenopathy, you should have red flags going off. HSP, or Hennig-Stollen purpura, is a small vessel vasculitis, and like ITP, it can present after a recent ERT. And the clinical classic tetrad is palpable purpura, joint pain, abdominal pain, and hematuria. But all 4 of those things do not need to be present at once for the diagnosis to be made. It may just indeed be 1 or 2. And the diagnosis is usually clinical. They have a classic non-blanching rash over the lower limbs and buttocks, as well as they can have sore joints. They can be edematous and have abdominal pain. Urinalysis can help identify if there's a renal component at play, and then if there's got severe abdominal pain, then you might consider doing an abdominal ultrasound. Management is mostly supportive, so rest, hydration, analgesia. NSAIDs if their kidneys are normal and if their platelets are good too. But the key to management here is that they need their urine and their blood pressure monitored regularly to monitor for renal sequelae. So weekly for the first month, fortnightly from weeks 5 to 12, and then single reviews at 6 and 12 months. Steroids are usually used if there's severe abdominal pain, renal involvement, or orchitis. Next, we have haemophilia, another big topic that I won't be covering in enough detail. Inherited coagulopathy. Just like I'm about to talk about with thalassemia, with these coagulopathies, family history is going to be the thing in the exam question stem or the apex that really is pointing you in this direction. And usually it's a family history and plus or minus a personal history of prolonged bleeding after hemostatic challenges. So a little baby who bleeds excessively after a circumcision or an injection, and dad needed to go to hospital after having his wisdom teeth out because he bled so much, or something like that. When you examine them, depending on where you're seeing them in the presentation, they might have hemarthrosis or muscle hematomas, or bruising. Coagulation studies usually reveal raised APTT but normal PT and bleeding time. And then factor 8 or factor 9 assay can confirm the type. So factor 8 is A and factor 9 is B. And then the management is obviously very much hematology guided, and it depends, I guess, on where you're seeing them in the course. So if they're acutely bleeding, then it will prompt factor replacement plus or minus transfusion. Then prophylaxis for severe cases might involve regular factor infusions. And then you want to try and avoid things like IM injections and NSAIDs. They always have a management plan, and they are usually under long-term hematology follow-up. Thalassemia, as we just spoke about, family history is key. Ethnicities are another important factor in a presentation of this. And on the right is a patient-centered summary of what can eventually happen in untreated and unknown thalassemia major. Tests are your full blood examination, which can reveal a microcytic anemia. And if you remember in the diagram before of the RCH approach to anemia, it's an important one to, when you're thinking about microcytic anemia, iron studies are really useful in determining cause. So they can be normal, which then obviously points you away from the direction of iron deficiency anemia as a cause. Hemoglobin electrophoresis and newborn screening as well too. Depending on whether or not it's minor or major really guides management. So the clue is in the name. Usually if it's minor and they're asymptomatic and otherwise well, there's not much that you do. And genetic counselling is one of the key parts. If it's major and they've got severe anemia, they may require regular transfusions, and they may indeed become transfusion dependent, but they need their growth and their cardiac and their liver function monitored. And then in really, really, really severe cases, bone marrow transplant might be required. So to wrap up, think broadly about bruising and bleeding. Unexplained bruising and bleeding, trauma, coagulopathies, platelet disorders, vasculitis, liver disease, nutritional deficiencies, and malignancy. That's the way I think about it, but develop your own approach, but just cast a wide net. Use a systematic approach with targeted history, exam, and investigations to categorize your differentials. And use your FBE well. Learn the components of it on their own individually well, and then learn how to interpret it in a clinical context. I've been taught many things about the FBE that I had no idea about. For example, just recently I was one of the most overlooked parts of the FBE is reticulocytes as a proxy for bone marrow function. That's just one example. So get comfortable with it. It comes up in adults as well. Recognize the red flags as always. Systemic symptoms and non-accidental injury, really important to keep an eye out for. Heme conditions can be very complex. Every year I have to relearn the coagulation cascade, and so I can appreciate the level of difficulty sometimes in approaching them. But I think the key to this is not knowing every specific detail about all hematological conditions. It's rather being able to spot the concerning features and escalating them appropriately, which is true for all pediatric presentations and indeed medicine in general. So all the best for your exams and apexes. And as always, please reach out if you have any questions or concerns. Thanks.